My name's Andrew Edwards, and this is the last talk for the evening, and this is a talk on a new technique, a new ultrasound technique in women's health, which is the ultrasound assessment of the pelvic floor. So the concept of pelvic floor ultrasound is that it allows us to look inside the pelvis and the region of the pelvic floor and look at the relationship of the pelvic organs to the pelvic floor, and also look at the structure and function of the pelvic floor. So just a little bit of a reminder here. The pelvic floor is the muscles really are at the base of the pelvis, and in my mind they're sort of like a trampoline, if you like, of muscles that insert around the rim of the pelvic bones. And the important thing is that there's a gap or a hiatus anteriorly where the urethra, vagina and anus or bowel pass through the pelvic floor. So this is obviously sort of an internal anatomical view, and this is sort of a sagittal view, sort of showing the concept of the floor, and particularly this levator ani group of muscles which sort of form a sling around the urethra, vagina and anus as they pass through the pelvic floor. When we have pelvic floor dysfunction, I guess in simple terms, there's sort of two main groups of symptoms. The first is the symptom of pelvic organ prolapse, or vaginal prolapse, and this will occur in up to 50% of women after childbirth, and 10 to 20% of women will require surgery for that. And just a schematic here showing the normal relationship of the pelvic floor. This is the pubic bone, and you can see bladder and urethra, uterus and vagina, and sort of rectum and anus here. So this is a cystocele, so the bladder prolapsing through the anterior wall of the vagina. This is a uterine prolapse, where actually the cervix is right down to the level of the introitus, and here is a rectocele, where the rectum is prolapsing through the posterior wall of the vagina. The other group of symptoms are sort of functional symptoms, so urinary and bowel symptoms. Urinary symptoms being by far the most common group, and the most common type of urinary symptom with pelvic floor dysfunction is stress incontinence, although some women will describe urge incontinence and some women will have voiding dysfunction or difficulty passing urine. And the little schematic here is just to remind me to tell you that these symptoms affect between 1 in 3 and 2 in 3 women after childbirth at some stage. So, as I said, the concept with pelvic floor ultrasound is to actually look at the structure and function of the pelvic floor and the relationship to the pelvic organs. So the indications are generally prolapse, symptoms of prolapse, urinary symptoms as I've discussed, and bowel symptoms. And the bowel symptoms are particularly obstructed defecation, fecal incontinence, or in some women a feeling of incomplete emptying. This is the way it's done. So it's done with a transperineal, or some people call it a translabial approach, where the ultrasound probe is rested against the perineum or against the vulva, but it's not an internal scan as such. And we use a 3D or 4D probe, and that helps us to reconstruct the images of the pelvic floor, which I'll show you shortly. So here's our schematic of the pelvic floor. So the first thing is that by convention, ultrasound sort of turns the image upside down. So this is how I have to sort of show you how that works. And then on this image here on the right, you can see the different parts. So this is the pubic bone, this is the bladder and urethra, this is the uterus, and this is the rectum. So if I put a little line across here, this is roughly the level of the pelvic floor. So the pelvic floor is running from the pubic bone and across and forming this sling going around the back of posterior part of the rectum there. So I want to show you a couple of examples of what we see regarding pelvic organ prolapse when we do this test. Now the way it works is we stress the pelvic floor, or test the pelvic floor, by getting the woman to do a prolonged Valsalva for approximately 8 seconds. And when we do that, we can look at the bladder and bladder neck. We can see how the bladder descends and whether there's rotation or change between the orientation of the urethra and the bladder. And we also look at the urethra and the rectum. So just to show you here, this is our pelvic floor. Again, running from the pubic bone and around the back of the bowel. So I'll just take that off and then I'll play the video. So if you look here, you can see the bladder. So she's about to do a Valsalva, this lady, and you'll see what happens. So the bladder, as she really pushes down, and you can see it's protruding into the anterior wall of the vagina there. And if we just freeze this, and I'll put the line back for the pelvic floor, so you can see that her bladder started well above the pelvic floor, and now it has descended down past and through the pelvic floor, so it's right through the hiatus, so that it's actually a couple of centimetres below the base of the pelvic floor. So this is a significant bladder prolapse, so you can see very clearly. So I'll go to another case. So the similar sort of thing. Here's the level of our pelvic floor, so running from the pubic bone. So in here we've got urethra and bladder up here, vagina's around about here, you can see, and this is bowel around about here. Now this is a patient who's had a hysterectomy, so when she does her Valsalva, you'll see what happens. Bearing in mind that she presented with symptoms of a prolapse, which was assumed to have been a bladder prolapse, so you'll see what happens here. So she's starting the Valsalva, and have a look in this region here, you can see what comes down, right down here. So this is small bowel. So this woman has an enteroceal, small bowel pushing right down, and if we put our pelvic floor back on, you can see that this small bowel has come right down. It's gone right down several centimetres below the level of the pelvic floor. So a very significant enteroceal. And enteroceals can be very difficult to diagnose, and rather than guessing what is going on by using this ultrasound, we're actually looking in there and seeing exactly what's going on with the organs of the pelvis in relation to the pelvic floor. The other thing we do is we look directly at the levator ani muscle. So the levator ani is that important part of the pelvic floor because it forms the sling and around the hiatus, if you like. And unfortunately, the levator ani avulsion is quite common, particularly in relation to childbirth, and the main risks are large first baby and forceps delivery, and the risk increases by 3 to 5 times in women who have a forceps delivery compared to a normal delivery. And some people consider the levator ani avulsion to be sort of the missing link between vaginal childbirth and prolapse. So we use a technique where we do a 3D reconstruction of the image, and we can actually see the levator ani. So this is a diagram here. So this is the pubic symphysis, pubic ramus here and here, and this here is actually the levator ani going around the hiatus, so urethra, vagina and bowel. And here's a case of a woman who has a defect in the levator ani that you can see quite clearly there. And the way we actually do this is we do multiple slices through the fibres, let's go back, multiple slices through the fibres of the levator ani so that we can actually check the fibres in detail. So this is a normal levator ani. We concentrate on these middle 3 images where it's all clearly intact and symmetrical. But versus this one here, we see that there's a defect on the patient's left here. So that's levator ani assessment. The other thing we do is we look at the hiatus, and because there's good evidence that enlargement of the hiatus is strongly associated with prolapse. So if the hiatus or the levator ani gets overstretched with childbirth, it may never get back to a normal live size. And here are 3 images of a scaled levator ani, scaled hiatus, and you can see this is a normal size. This is sort of borderline between normal and enlarged, and this is a clearly enlarged hiatus, and we measure that in an objective way by measuring the area. So in conclusion, pelvic floor ultrasound is a new way of assessing the pelvic floor and organs, and it's really changed these things very dramatically. It's particularly useful for the investigation of symptoms of prolapse and urinary incontinence. It's completely reasonable for general practitioners to refer to us for this test. It's been widely used by the gynaecologists in Australia, but much less commonly used by the general gynaecologists and by general practitioners. But it gives us such useful information and such clear information that will help to guide management. That is something that we're really hoping to be starting to do in much bigger numbers. And I thank you for your attention.